is Luis. I'm a final year med student. Okay, here, sorry, wait a moment. Here. It's an honor to present before you today our work, Mind the Gap, a systematic review of depression, barriers, and facilitators to mental health care after miscarriage. The topic I'm about to discuss is one that even as students, we quickly learn is a frequent event in clinical practice, miscarriage. But what this research has told me is that behind this common clinical event lies a profound silence. Today, I want to talk about that silence and what it reveals about a critical care gap, a gap not just in our healthcare systems, but perhaps in our own medical training. This silence leaves millions of women at high risk for clinical depression, with little to no formal support. This presentation is about that silence. It is about a critical care gap in this specialty, a disconnect between patients' profound suffering and the healthcare response they receive. To make this tangible, think of the patients we observe. A woman is told her loss is common and just to try again. She leaves the clinic without a follow-up plan for her emotional well-being, feeling dismissed and alone. This story is repeated in countless healthcare systems globally, and it's the story this research aims to change. To understand this gap, we conducted a systematic review following PRISMA guidelines. We screened over 1,100 records and ultimately synthesized the findings from 46 studies that evaluated depression and barriers to mental health care after miscarriage. As we synthesized the data from 46 studies, one of the most compelling patterns that emerged was a clear dose-response relationship. As we can see in our figure, the risk of depression is not static, it is cumulative. With its subsequent loss, the psychological burden grows. This is clinically critical because it reframes recurrent loss not just as a reproductive issue, but as a compounding psychological trauma. The largest psychological shift often occurs between the first and second loss, highlighting a crucial window for interventions. But this risk is not uniform. Our review confirms that this vulnerability multiplies in specific patient profiles that we must learn to identify. Women with no living children, those with a prior mental health history, and those who lack strong social support. This vulnerability leads to what the literature clearly identifies as the care gap. The disparity we found is staggering. While studies show nearly half of women report significant depressive symptoms, our review confirmed that only a fraction, around 16%, had actually seen a mental health professional. It's important to note that this nearly 49% figure comes from self-report scales, which measure significant distress. The prevalence of a clinically diagnosed major depressive disorder is lower, around 10 to 15%. But the core message is the same. A vast amount of psychological suffering is being systemically overlooked. This is the gap we are here to discuss. This is the gap we must close. So, why does this gap exist? The barriers are clear. First, from the healthcare system, women report insensitive communication and a critical lack of follow-up from the healthcare team. And this isn't just an isolated perception. One study found that over half of women, 52%, were dissatisfied with the follow-up arrangements offered to them. Second, from society, they face stigma and what's known as disenfranchised group, a loss that isn't fully acknowledged. And finally, practical barriers such as cost and a simple lack of information about available services. And this isn't about providers being unkind, it's about a gap in training. And this is where my perspective as a student becomes relevant. We are extensively trained to manage the physical aspects of miscarriage, but the skills for compassionate communication and psychological follow-up are not always integrated into our core curriculum. The evidence shows that well-intentioned comments like focusing on future pregnancies often invalidate a patient's current grief, worsening their sense of isolation. Conversely, what helps? The facilitators were remarkably consistent. First, strong social support. A compassionate partner, family, and friends are profoundly protective. And second, from us, empathetic, high quality healthcare, simply taking the time to talk and validate the loss was described as powerfully therapeutic. Interestingly, we found a paradox when it comes to formal interventions. Less structured support, like a single debriefing session, was highly valued by patients for the empathy it provided. However, it showed no significant effect in reducing clinical depression scores. On the other hand, structured therapies like cognitive behavioral therapy or CBT did show a significant reduction in symptoms. But these interventions faced major barriers, including high cost and patient reluctance, with one study reporting a 70% refusal rate. This suggests that empathy is necessary, but may not be sufficient to treat a clinical disorder. Crucially, we must also acknowledge that the evidence supporting these structured interventions is still preliminary and comes from studies with notable methodological limitations. So, how do we bridge this gap and resolve the paradox? The evidence points toward a universal stepped care model. One, psychoeducation. Every single patient should receive clear, supportive information about the emotional impact of miscarriage. This is the universal foundation. Step two, screening. At a 4 to 6 week follow-up, we must formally screen for psychological distress using a validated tool. Step three, referral. And for those who screen positive, we need established, efficient pathways to structured, evidence-based therapies like CBT. Of course, our review has limitations. The studies included had significant heterogeneity, which prevented a formal meta-analysis. Furthermore, the variable methodological quality of many included studies means our conclusions on interventions efficacy must be interpreted with caution and should be seen as preliminary. For future research, we urgently need high quality randomized controlled trials to establish which interventions are most effective. We also need to focus on vulnerable populations, like women without living children, and importantly, include partners in the development of couple-centered care. In conclusion, the evidence presented today is unequivocal. Psychological support cannot be an afterthought. It must be an integral part of standard miscarriage care. As we prepare to enter the medical field, this research highlights a clear path forward. By adopting this model, the specialty can move from passive observations to active support, and finally ensure patients are not left to suffer in silence. Thank you very much for your time and attention. I want to extend
like we were doing audit presentation and everything. So this is just a simple case of unilateral tubal torsion, which we came across recently. So why this case presentation is important? Because we see women with the lower abdominal pain every now and then in A&E and in gynae practice also. But it causes quite a bit of diagnostic dilemma for us as a clinician as well. So we saw this lady who came in A&E, 33-year-old, and she came in with acute pain in the left iliac fossa and some pain in the suprapubic region. There was no aggravating or relieving factor. Her LMP was 1 week back. The urine pregnancy test was negative, and she had a background of bilateral tubal ligation, which was done 2 years back along with her cesarean section. She was para 3. She had one vaginal delivery and two cesarean section. On examination, she had a news of two. She had temperature of 38 degree, pulse was 96, respiratory rate and blood pressure were normal. On examination, she had tenderness over the left iliac fossa. There was no mass felt though. She also had some suprapubic tenderness. On her urine test, we also found that there were some nitrites positive. So we were thinking that possibly this could be a UTI also. So we started her with the antibiotics according to the hospital guideline. Our background, our impression for about this case was is a PID or an ovarian accident along with the UTI. On investigations, hemoglobin was normal, white cells slightly raised but normal, but CRP was quite raised, 249. UNEs and LFT were perfectly normal. As we said, there was nitrites positive in her urine. So we did a CT scan for her, which was done actually in the A&E, and they said that there was two adnexal cysts measuring about 3.5 centimeters with some free fluid suggesting of cyst rupture. So we brought her to so she was obviously referred to gynae, and we saw her in gynae, and then we admitted her. We were managing her conservatively. Uh, However, her pain did not settle down with antibiotic and pain relief options. So we did an ultrasound scan again to see what is exactly happening. So on ultrasound, which was done a day later, there was a left ovary which was enlarged and edematous, central heterogeneous whirlpool appearance suggestive of ovarian torsion. So as it is an emergency, we took her to theater for a diagnostic with or without operative laparoscopy with consenting for oophorectomy and or oophorectomy. Sorry. Uh, as we can see on the scan findings, also we can see a cystic structure over here, and when we took her for laparoscopy, we could see that there was lot of adhesions on the left side. The sigmoid colon was adherent to the left fallopian tube. There was omental adhesions also on the left side and the anterior abdominal wall. Both ovaries appeared normal though. Right fallopian tube was also normal. The left fallopian tube, as we can see in the last picture, it showed a very dotted and gangrenous structure, which was around 5 to 6 centimeters, with grade 4 ischemia indicating significant loss of blood supply. And there was considerable inflammatory changes on the left side. The histopathology, obviously, it confirmed our diagnosis. It showed that there was a dilated portion of fallopian tube with attached femoral end measuring about 45 by 45 into 30 millimeter, consistent with the left fallopian tubal torsion. So this case highlights the importance because since the first thing which comes to her mind with any women with left iliac fossa or right iliac fossa pain is to rule out ectopic pregnancy. Since she had a bilateral tubal ligation, we thought that okay, it's definitely not an ectopic pregnancy, but we were not sure what is happening. So there is a grading of fish ischemia, which was done by which is called as a parical grading. which showed grade 1, which is slightly discolored, normal size, with which promptly reverted to normal color after detorsion. So this is the same grading as we do for ovarian torsion. So grade 2 is dark red to brown in color, mildly enlarged with edematous, which becomes hyperemic after detorsion. Grade 3 is brown to black in color, grossly enlarged and edematous with slight improvement in color after detorsion. And grade 4 is complete black, necrotic, and no improvement of color after detorsion. So this is what we had in this women. So she made a good recovery after the surgery, and she was sent home the next day. So discussion about this case is that acute abdomen is a frequent presentation in women with reproductive age, commonly accompanied by symptoms like lower abdominal discomfort, nausea, and vomiting. As there are some differential diagnosis, this diagnosis of having is- unilateral tubal torsion is quite rare, and we are not sure if this is underreported, or we are not aware of this condition. So in this case report, we do present a provisional and preoperative diagnostic of tubal torsion. Sorry about that typo. It's a common diagnostic dilemma which we come across. Systemic review which was done in 2024, which included 131 patient, which showed isolated fallopian tubal torsion based on published case report. This case illustrates the diagnostic complexity of the rare entity and the emphasis that its importance of a prompt surgical intervention. Um, so that is all. Thank you for allowing me to present this case. Does anyone have any questions?
For presentation is perception of fertility, quality of life, and depression in women undergoing assisted reproductive treatment. Infertility is a disease that affects nearly 15% of couples who are trying to get pregnant. According to the World Health Organization, it affects 50 million to 8 million people worldwide and nearly 8 million people in Brazil. And a couple is deemed infertile when its odds of conceiving are reduced, but this can be circumvented by medical measures. Most common causes of infertility are tubal peritoneal factors, male factors, hormonal factors, or unknown factors. The most common assisted reproduction techniques are in vitro fertilization, or IVF, artificial insemination, intracytoplasmic sperm injection, and other two modalities that are less frequent in the Brazilian context are gamete donation and surrogacy. Recourse to IVF is only had when artificial insemination is not indicated. However, in cases of advanced age or severe male factors, it is indicated as a first-line treatment. IVF has been described as a multidimensional stressor, as it involves both features pertaining to the experience of infertility as well as those related to the treatment itself. Although male partners often experience embarrassment caused by issues related to manhood or semen collection, women suffer the bulk of the treatment demand, being subjected to countless invasive tests, having to follow strict drug prescriptions, and receiving high doses of hormones. In this context, it is hard to tell the impact of infertility apart from that of treatment. We made a quantitative-based cross-sectional study. The sample included 89 participants who were enrolled in the assisted reproduction program of Hospital de Clínicas de Porto Alegre, outpatient fertility clinic, and data collection extended from August 2016 to January 2018. The inclusion criteria were age 35 years or younger, no previous explicit diagnosis of any mental health disorder, and no previous diagnosis of organic diseases. All the women enrolled were included. Those were administered in the following sequence. the socio-demographic data questionnaire, the fertility FertiQual, back depression inventory, and finally the fertility problem inventory. The social demographic data questionnaire is used to characterize the sample included items on age, ethnicity, place of birth, etc. The FertiQual assesses core and treatment-related quality of life and overall life and physical health items. The back depression inventory is used worldwide to detect depressive symptoms, and the fertility problem inventory measures infertility-related stress related to social concern, sexual concern, relationship concern, rejection of child-free lifestyle, and need for parenthood, based on a 46-item scale. We made categorical variables described as absolute and relative frequencies, and quantitative variables as means and standard deviations. Normality of continuous variables was verified through the Shapiro-Wilk test, and vertical scores were compared with clinical and social demographic variables using students' t-tests and analysis of variance. Variables with p-values less than 0.2 were included in the multivariate linear regression model to check for independent association with vertical. Associations between FPI and vertical scores were assessed through the Pearson correlation coefficient, and all analyses were performed in the post-W statistics. The sample included 89 participants, and regarding demographic characteristics, 81% were above the age of 30, 73% had completed secondary education, 86.5% worked or were otherwise economically active. In relation to clinical characteristics, 84% had never had children, 33% had already had a previous assisted reproduction experience. In nearly 84% of cases, the cause of infertility was on the female side. 14.6% had a history of miscarriage. 22.5% were BDI positive. The mean overall vertical score was 70.9. This is table 1, 2, 3, and 4. The full tables with its analysis can be found in our full article. It can be found on PubMed. The title is the same of the presentation. Our results are as follows. The patients with BDI-induced depressive symptoms scored 11 to 23 points lower on the vertical. Patients with primary or secondary education alone had better quality of life scores, except for the core emotional and treatment environment subscales, when compared to patients with higher education. The difference in scores among patients with different levels of education, so primary and secondary versus higher, range from 9.1 to 24.9 points. The vertical provides a disease-specific, accurate measurement of the impact of infertility on quality of life, being a useful tool to assess quality of life in infertile couples. The FBI reviews the impact of infertility experience on several domains of people's lives, social, conjugal, and sexual, as well as the importance of parenthood in the respondent's life by evaluating the desires for parenthood and rejection of a child-free lifestyle. And most importantly, our study findings regarding vertical show the same response pattern found for FPI-related findings, corroborating the work of Maura Ramos from 2008 and 2011, which investigated the factorial structure of the FPI, focusing on its relevance in clinical practice. There is a relationship between depression and physical health. Depression results from a complex interaction of social, psychological, and biological factors, and accordingly, depression is also associated with quality of life. In our sample, the mean total/overall vertical score was 66.5 and showed a significant association with depression and educational attainment. So patients with depression had on average a 10.7 score gap in relation to those who had no depression. Our findings corroborate that infertility is associated with depression and lower quality of life. Therefore, we believe the inclusion of a psychologist with specialized training in assisted reproduction in the treatment team is essential. Psychological assessment could bring to light factors that contraindicate assisted reproduction treatment altogether. Those who had completed only primary or secondary education reported a better quality of life compared to those who had completed higher education, with 11 and 11.4 point gaps respectively. It also bears noting that in our sample, patients with higher educational attainment also had higher depression levels. Assisted reproduction providers should be aware of this phenomenon and of the multiple factors potentially involved, and should offer psychosocial care before, during, and after treatment. Our findings corroborate previous literature, which has associated female infertility with depression and lower quality of life, as demonstrated by the significant negative correlation between the mind-body vertical, subscale, and the BDI. Participants with BDI scores consistent with depression scored on average 13.4 points less on the scale than their peers without depression. This study has relevant implications for research. The FPI seems to be a suitable tool to measure infertility-related stress, as it provides a comprehensive assessment of stress associated with infertility in several areas. It can also be used for clinical settings for screening purposes by identifying particularly troublesome aspects and risk of emotional distress in men and women facing infertility. A comprehensive approach to infertility care that incorporates the promotion of emotional health involves challenges, including the rebirth of hope. We suggest the future research could focus on the conjugal relationship within the context of depression and postpartum depression, searching for a possible association in women who have been diagnosed with infertility. Postpartum depression is not always noticed by the family members or healthcare professionals. Therefore, new studies on the intensity of distress caused by infertility involving professionals who are in contact with this population and are aware of the needs for psychological assessment are needed. This would articulate the diverse knowledge compartmentalized within the most varied fields of knowledge without losing sight of the essence and particularity of each phenomenon, reconnecting matter and spirit, nature and culture, subject and object, objectivity and subjectivity. And these are our references. And thank you. Are there any questions?
Thank you, Giz.
De Armenia, Colombia.
So today we're presenting the ABCD study for preeclampsia in the cohort women in Colombia and Armenia Quindío.
ABCDE son las siglas. A significan A, antecedentes de riesgo de preeclampsia, B, biomarcadores, C, citoquinas, D, niveles de vitamina D y E, hallazgos ecográficos.
The ABCD study stands for A, meaning the history of preeclampsia or antecedents, B for biomarkers, C for the cytokines, D for the vitamin levels, and E for the ecographic findings.
Soy médico, ginecólogo y obstetra en Armenia, Colombia, estudiante de doctorado en ciencias biomédicas, Universidad del Quindío. Mi tutor es el doctor John Carlos Castaño Osorio.
I'm a doctor, gynecologist, and obstetrician. Currently, I'm a PhD student at the University of Quindío in Armenia, Colombia, under the supervision of the PhD John Carlos Castaño Osorio.
Bien, la preeclampsia consiste en una elevación de la presión arterial en una mujer embarazada que tenga más de 20 semanas y que tenga una de las siguientes cosas: proteinuria mayor a 300 miligramos de decilitro, o una crisis hipertensiva, o una trombocitopenia, o una elevación de enzimas hepáticas, cualquiera de estas complicaciones.
Preeclampsia is currently recognized when a pregnant woman after 20 weeks of gestation presents with elevated blood pressure above the 140/90 and one of the following conditions: proteinuria, hypertensive crisis, thrombocytopenia, or hepatic involvement, among others.
Bien. Para esta diapositiva, existe en el embarazo un modelo que se llama remodelación vascular, en el cual las arterias espirales son invadidas de trofoblasto para que estén dilatadas. Entonces, eso se llama remodelación vascular.
In this graphic, we can see the process known as vascular remodeling, which aims to transform the spiral arteries into dilated vessels as they are invaded by the trophoblast.
En la parte superior, entre las 8 y 18 semanas, podemos ver que se da una adecuada remodelación vascular, presentándose moléculas que son angiogénicas, como la interleuquina 10 y el factor de crecimiento placentario.
At the chart, we can see the normal process for the vascular remodeling from the week 8 to 18.
En la parte de abajo podemos ver cuando no se da una buena remodelación vascular en la preeclampsia, y las moléculas que se manifiestan son antiangiogénicas. Entre ellas están la interleuquina 18, la interleuquina 6 y el factor soluble de tirosinquinasa 1 o SFLT1.
At the bottom, on the contrary, we can see the angiogenic molecules such as the interleukin 6, interleukin 18, and the SFLT1, which prevent the proper vascular remodeling. In the chart, we can see that the angiogenic molecules, as the placental growth factor and interleukin 10, they increase as normal.
El problema está en que la preeclampsia la diagnosticamos solo por encima de las 20 semanas, donde se dan las manifestaciones clínicas. Por debajo de las 20 semanas no tenemos un modelo de predicción certero.
The main problem today is that we can only diagnose the preeclampsia after 20 weeks up to the normal 40 weeks, once the clinical symptoms appear. So far, there is no medical process in order to prevent it before the 20 weeks.
Y el único tratamiento que tenemos es interrumpir el embarazo cuando hay una cuando hay una preeclampsia severa, sin importar la edad gestacional.
So far, the only treatment that we had is when the preeclampsia becomes severe, it is to end the pregnancy regardless of the gestational age.
El objetivo de este estudio fue caracterizar o explorar la capacidad predictiva de algunos biomarcadores como la relación o cociente SFLT1 y factor de crecimiento placentario, la vitamina D, las citoquinas y los hallazgos ecográficos en una cohorte gestante de Armenia.
The overall objective of this study was to characterize and explore the predictive capacity for preeclampsia of the SFLT1, the PLGF, the vitamin D level, the cytokines, and clinical and ultrasonographic features in pregnant women from Armenia, Colombia.
Se diseñó un estudio prospectivo observacional de cohorte, tomando 170 gestantes y vigilándolas durante el embarazo hasta que terminaran su gestación, ya sea porque cumplieron el tiempo de gestación o porque les dio preeclampsia.
As for the design, a prospective longitudinal cohort clinical study was designed. A total of 170 pregnant women were enrolled and followed throughout their pregnancy until gestation ended, either because they completed the full term or developed preeclampsia.
Durante el seguimiento se tomaron biomarcadores en donde está marcada cada una de las estrellas, es decir, en 4 momentos. El primer momento entre 8 y 12 semanas, el segundo momento entre 18 y 20 semanas, el tercer momento entre 30 y 34 semanas y el último momento al terminar la gestación.
During this period, blood biomarkers were collected and clinical evaluations were performed at 4 specific time points, each one marked with a star. These were the visit 1 between the weeks 8 to 12, visit 2, weeks 18 to 20, visit 3, weeks 32 to 24, and visit 4 at the time of the delivery.
Al final, se tomaron dos grupos, uno que desarrolló preeclampsia y uno que no desarrolló preeclampsia.
At the end of the study, the participants were classified into 2 groups, those who developed preeclampsia and those who didn't.
Todas las pacientes se valoraron en el Centro de Salud de la Universidad del Quindío y en el Centro Happy Maternity, y se le hicieron siempre tres cosas, que fueron la evaluación de las variables clínicas, el ultrasonido y la toma de muestras sanguíneas, las cuales se llevaron al laboratorio para los respectivos inmunoensayos.
The pregnant women were evaluated at the Health Center of the University of Quindío and or at the Happy Maternity, a maternal care center. Clinical assessment, ultrasounds, and blood samples collections were performed at these sites. The blood samples were then transported to the biomedical laboratory for processing using immunoassays.
Los grupos, tomamos entonces un grupo 1 de pacientes saludables y un grupo 2 de pacientes con preeclampsia.
For the group classification, we found the population was classified into 2 groups. The first one included the healthy pregnant women, and the second one included pregnant women with preeclampsia.
Esta tabla nos muestra las variables clínicas, los resultados de las variables clínicas en las cuales podemos ver en general, los sujetos en general, el grupo 1 de saludables, el grupo 2 con preeclampsia y sus diferencias estadísticas. Y podemos ver, por ejemplo, que la edad y la multivariedad no tuvieron una significancia estadística en este estudio.
In this table, we can find the results, or we can observe that age didn't yield a significant p-value, nor did the multiplicity.
Sin embargo, en la parte inferior podemos ver cómo sí hubo una significancia importante en el hecho de tener un antecedente personal de preeclampsia y en el hecho de tener, y en el hecho de tener un índice de masa corporal elevado.
However, we can see that a personal history of preeclampsia and the body mass index greater than 25 showed statistically significant p-values.
El Doppler de arterias uterinas se realizó por un solo observador, quien fue la doctora Liliana Pachón Vivas, que se dedicó a hacer únicamente los Doppler.
The uterine artery Doppler examinations were performed only by the expert obstetrician Dr. Liliana Pachón.
El Doppler de arterias uterinas mostró que cuando eran negativos, realmente no tuvieron preeclampsia el 85%, pero cuando eran positivos, el 3.2% sí presentó preeclampsia.
The results showed that 85% of the women with a negative Doppler didn't develop preeclampsia. In contrast, 3.2% had a positive Doppler and developed preeclampsia.
Ese análisis clínico de las variables nos muestra, en el caso de que el antecedente familiar de preeclampsia, el índice de masa corporal mayor a 30 y el Doppler de arterias uterinas positivo daba un RR significativo para preeclampsia.
This chart displays the relative risks for the clinical variables. We can observe that a family history of preeclampsia and a BMI over 30 showed a significant relative risk, and the uterine artery Doppler test positive also reached statistically significance.
Para los inmunoensayos se tomaron de 159 gestantes, 42 de ellas para completar 168 muestras.
For the immunoassay, samples were taken from 42 out of the 159 pregnant women, resulting in a total of 168 samples.
Vemos esta tabla en la visita 1, es decir, 8 a 14 semanas, que la interleuquina 10 y la interleuquina 18 mostraron que, comparando el grupo 1 saludables con el grupo 2 de preeclampsia, su p-valor era significativo.
When comparing the mean biomarker levels at visit 1 between the healthy women and the ones who developed preeclampsia, the p-value was significant for the interleukin 10 and 18.
En esta tabla, la visita 2, de 18 a 20 semanas, podemos ver que fue significativo el factor soluble de tirosinquinasa 1, por ejemplo, y sigue siendo significativa la interleuquina 10 la interleuquina 6 y la interleuquina 18.
During visit 2, besides the interleukins, the p-value was significant for the interleukin 6 and interleukin 18, as well as the SFLT1. They showed a significant difference.
Se hicieron unas curvas ROC, operador receptor para prueba diagnóstica.
We perform a receiver brain characteristic curves as a diagnostic way.
Encontramos que para la vitamina D, en las primeras 2 visitas, no hubo, sobre todo en la segunda visita. En la primera visita hubo una moderada significancia estadística, mientras que en la segunda visita no hubo significancia estadística para predicción de preeclampsia.
It can be observed that vitamin D levels in both visits before the 20 weeks do not appear to be predictive of preeclampsia, showing low sensitivity and specificity, although its significance is greater in visit 1 than in the visit 2.
Para el ratio SFLT1 PLIG o factor de crecimiento placentario, la curva ROC no mostró significancia estadística en la primera visita, y en la segunda visita sí mostró una significancia con un punto de corte de 39,2.
Likewise, the ROC curve for the SFLT ratio shows a low value at the first visit and improves near 20 weeks, which corresponds to the second visit with a cutoff point of 39.
La interleuquina 6 mostró una excelente significancia estadística desde la primera visita y en la segunda visita con unos puntos de corte de 5 a 6 picogramos mililitro.
The ROC curve for interleukin 6 shows an excellent statistical performance for predicting preeclampsia before the 20 weeks, with a point from 5 to 6.
La interleuquina 10 no nos mostró una adecuada significancia estadística en las 2 visitas.
On the other hand, the interleukin 10 didn't demonstrate a prediction capability during the 2 visits.
Sea clara que estamos tomando 2 visitas porque estamos hablando de la predicción antes de las 20 semanas.
It is really important to take into account that we are focusing mainly on the first 2 visits before the 20 weeks, as that is the aim for the study in order to predict the preeclampsia before the 20 weeks.
La interleuquina 18 mostró una excelente sensibilidad y especificidad con un p-valor por debajo de 0,005 para predicción de preeclampsia.
The interleukin 18 demonstrated an excellent prediction before the 20 weeks with a cutoff range of 210 to 219.
El riesgo relativo tomado entonces la interleuquina 6, la interleuquina 18, incluso la interleuquina 8 nos mostraron un RR con una significancia estadística para predicción de preeclampsia.
In conclusion, the interleukin 6, interleukin 18, and even the 8 demonstrated strong and statistically significant for the finding.
Se hizo un modelo de regresión logística para la visita 1 para ver una inferencia estadística, la cual nos arrojó el 95% cuando se combinaban varios biomarcadores.
For the measurement, it was based on a statistically inference and regression model was created combining biomarkers and clinical findings, and these were integrated into software, proving that 95% when combined with biomarkers.
Aquí podemos ver el análisis de regresión del SFLT1 PLIP combinado con vitamina D, con interleuquina 10, con interleuquina 18, con la edad materna y con el Doppler de arterias uterinas, mostrando 95% de predicción.
Here we can see the regression analysis for the SFLT1 and the PLGF ratio. It was significant when combined with vitamin D, interleukin 10, interleukin 18, and uterine artery Doppler measurements, showing a 95% confidence level.
La interleuquina 6, combinada entonces con SFLT1 PLIC, vitamina D, interleuquina 10, interleuquina 18 y Doppler de arterias uterinas, mostró también ese 95% de predicción.
Interleukin 6 demonstrated a significant predictive effect when combined with vitamin D, interleukin 10, interleukin 18, the SFLT1, PLGF, and medical history, plus the uterine Doppler with the regression model providing a 95% confidence.
También con la interleuquina 18 se mostró una predicción cuando se combinó con interleuquina 6 y con antecedente médico o con antecedente de preeclampsia.
Likewise, interleukin 18 demonstrated a highly reliable predictive curve for preeclampsia when combined with interleukin 6 and the medical history of preeclampsia.
Como conclusiones, este estudio puede mostrarnos la predicción antes de la manifestación clínica, es decir, antes de las 20 semanas, donde podemos ver la elevación de sustancias inflamatorias como las citoquinas.
The study conclusions for the ABCDE study, it helps to understand the preeclampsia as a disease with a phase that precedes clinical manifestation, that is, before the 20 weeks of gestation, characterized by an elevation of inflammatory substances such as the cytokines.
Este estudio también sirve para, en un futuro, poder integrar nuevos biomarcadores antes de las 20 semanas. También para identificar moléculas candidatas para biomarcadores de preeclampsia y pues poder tener una predicción desde antes de las 20 semanas de esta enfermedad.
For the conclusions, this study lays the groundwork for the future integration of new biomarkers before the 20 weeks with the identification of candidate molecules as an early predictive biomarkers for the preeclampsia, and further study with larger populations are needed to confirm their predictive.
Thank you.
Thank you so much for your attention.
Thank you, Richard, for your presentation. It was
and I'm going to talk to you about a case report. And one of the objectives of this review is to see the literature, because it is relatively frequent, but it's not very well known for all the doctors. I'm a medical doctor. My specialty is gynecology and obstetrics. My subspecialty is urogynecology, and I do research focused on the fields of gynecology, obstetrics, and urology. So it is estimated that 5 out of every 1,000 non-immune pregnant women may become infected with toxoplasma. During pregnancy, infection can spread across the placenta to the fetus, resulting in intrauterine growth restriction, fetal death, mental retardation, eye defects, and in the most severe cases, blindness. So it is very important to detect it on time because there is treatment to this infection. It's based on antibiotics. So this clinical case is about a 35-year-old female patient. When we did the test, she was 13.4 weeks pregnant. And in the prenatal control studies, we found elevated IgM anti-Toxoplasma gondii antibodies, and they were detected on an index value of 1.1. So this was considered reactive, as you can see on these points that I wrote. The first report of anti-Toxoplasma gondii IgG antibodies were reactive too. So the IgM antibodies and the IgG were reactive. So here we had to see if this was, the time it had the infection, she had the infection. So subsequently, they were reported at 43.8, and we repeated the IgM antibodies, and they were on 0.3. So 2 weeks later, they lowered. So now we had positive IgG antibodies and negative or non-reactive IgM antibodies. 2 weeks later, it showed the value of 38.1 for IgG antibodies. So IgG means the infection has more than 3 weeks at least, but it can last positive for a lifetime. And IgM antibodies mean that the infection is acute, so it can be positive from the day 5 since the infection, but sometimes it can last even for a year. So here's why we have to keep repeating the studies to analyze that. So because we had 2 reactive tests, one for IgM and one for IgG, but then the IgM got non-reactive, we still decided to do the IgG avidity test, because this test, when it is high, we can determine if the infection was acute or non-acute. So in this case, the patient was lucky because we found it was 44.6%. That means it means it's not acute. So probably she got the infection some weeks before the pregnancy. So in this case, well, if you find that the infection is acute, you have to give them, you can do a study of the placental liquid, but you can also give them the antibiotic. When we are not sure, that's when we do the IgG avidity test. And when we know it was before pregnancy, we don't have to do any more studies. So after we did both studies and the avidity test, we got to the conclusion that it was before the pregnancy. In this case, the tests performed were not compatible with primary acute infection, so we didn't have to do any further testing of the fetus or the mother, and it was concluded that the reported toxoplasmosis was before the pregnancy. So there were no associated threat to the fetus, and we didn't do any more studies about those about the infection to the mother or the fetus. We did do a follow-up of the mother and especially of the fetus once she was born, and the baby was totally healthy. She had no problems with the site or any other signs that made us think that she was affected. But the objective of this is to be able to analyze the antibodies and get to the conclusion to act on time, depending on the case. Thank you. I don't know if there's any question.
Yeah, thank you.
Of the Central Medical Center in Mexico City. Today I'm honored to present the Gynecology and Obstetrics of fertility form, molar with monozygote term parents. This report was published in the Causes in the GOM 2024 and represented a patient example of the high-risk pregnancy that research turned with a level neuron despite the existence of molar pathology. Well, to provide the context, the term unilateral mode refers to a normal existing characterization below the excess, therefore acid perturbation and hydropic degeneration of chronic bleeds. This is a classification in two types, to complete and partial. And in this complete mode, these are embryonic or fetal tissues and they are below as on the endometrius will in the partial mode, where there might be consistent embryo of fetus showing a lot in below with both normal and hydropic will present. The epidemiology is among pregnancies are relative in common. The incidence of complete mole ranges found on 0 per 3 to 310 per 100 pregnancies, and the partial mole occurs in approximately 3 per 100 pregnancies. However, the coexistence of the life number of fetus is a molar pregnancy is extraordinary rate, estimated one of 100,000 pregnancies worldwide. In Mexico, the reporting size of molar gestation is around 2 per 4 male pregnancies. From the genetic perspective, Pachamama is a triplet and contains the maternal haploid set and two paternal sets of chromosomes, typical due to the spermatogenesis for a single ovum. This results in a karyotype such as an 69XXU, 69XXX, or 69XU. The overrepresentation of paternal genesis drives abnormal thoracic ground and placenta degenerations. In most cases, embryonic development is a complete evidence in early research. However, the coexistence of the partial molar placent and a live open fetus, especially on monochroic and monozygote pregnancies, is exceptional area that poses an important international management change. Let me describe in this case, the patient was a 22 years old woman, Alexa metoclopramide, with chronic disease, with a previous cesarean section 8 months before conception. She was referred on the department from the secondary care hospital home torsion suggesting a partial placent malformation consistent with a identical mode. Laboratory tests revealed markedly elevated HCG levels on the 18,000 in unit on the 1,050,000 and unit then 72 hours later. And 66 weekend of the platinum weight classification high rise to the short pregnancy interval describes in a molar process. Quadruple markers revealed with elevated levels on the ABHC hit and NBA, suggesting a possibly chromosomal anomaly, in particular 22. However, a late labor 2 ultrasound showed fetal structural abnormalities, and amniocentesis with fish analyzed operation and normal female karyotype 46XX. and the patient was frequently closed in multidisciplinary teams, including maternal fetal medicine specialists, geneticists, and obstetricians. At 36.2 weeks of gestation, gestation, she was admitted with a pound around the previous surgical scar. Given the suspension and authorization in this care, where the delivery weight stand and co-decision for model to perform a session section, all female neonatal with ability working to 20 novacy farm range and the average score of the 8th and 9th, and use normal malformations. The placing was incurred hydropic and cerebrovascular and characterization of more change, while this image of the placent, we know for visualization of the moral characterization with and this population examination confers the monochorial placent, which true population will build some and normal and others aromatic with the torsion, hyperplasia, irregular outset, and stromal fibrosis. The sprinting were considered with a partial congenital mode. Both the board on between newborns recorded with the complication and were stretching the condition. Well, in this case, on the scales of the carrying completely on moral pregnancy with available features, there's different diagnoses including with dependencies, with a completely moral section features, plus mesenchymal dysplasias, and choreangioma. Due to significant autosocial that are not always definitively specified in the early gestation. Well, in summary, in this case, an exception of testing the scenario with a partially identiform mole coexisting with a live monozygote fetus that receives down. The successful is a cause depends on the early diagnosis, comprehensive multidisciplinary care, and individual decision making regarding the determined model of the delivery. Partial molar pregnancy with a viable fetus, ulteriority, remains of the important non-integrant in advising the nursing methods, molecular genetics, and the maternal fertility medicine experts. Close without their delivery is essential to use of the patent suffer and prevent potential implantation and complications. Thank you very much for your attention. This is a mention of the child in this moment when don't know the visual of abnormalities in the actuality.